I'm Marie Yambo, coming to you from Afya House here in Nairobi, where we want to speak matters health. Now, promotive and preventive healthcare is key to the achievement of universal health coverage. Now, we know very well that the government has been working very hard to ensure that universal health coverage is achieved within the office of the new president, that is President William Ruto. And to speak to us more about the milestones that have been achieved on universal health coverage is none other than the Cabinet Secretary for Health, that is Susan Nakhumicha. Welcome to the program.
Thank you, Maria. I'm happy that you are here to hear from the horse's mouth.
Exactly.
In terms of the progress that we have made.
Asante sana. And hearing from the horse's mouth, let's start by you maybe giving us a brief. How has the journey been? What are some of the milestones that you can share with Kenyans in as far as UHC is concerned?
Thank you. His Excellency the President, while he was seeking office to become the president of this country, he did promise that he was going to ensure that there is universal health coverage. And that is basically to mean that there is access to healthcare without Kenyans suffering a financial loss. So within the year, we have been working. During that time, of course, there's a document that was developed, and it is famously known as the plan. So we have been working on how do we implement the plan, how we translate the promise to an implementable action and something that will be impactful to Kenyans. So for the past 1 year, we have been seeking clarity. And the good thing about it is that we have had to learn from lessons of previous failures. We have put all that together and come up with a critical plan on how do we then ensure that we achieve universal health coverage. To begin with, Maria, universal health coverage is not an end in itself. It is a continuous process of ensuring that we deliver good, quality, accessible healthcare to many Kenyans without them having to suffer financial loss. So as a ministry, in the past 1 year, we have had to think of how best do we do this? Because at the end of the day, it is the impact. And as you have rightfully put it, that now we have shifted focus from curative services to focusing on preventive, that we prevent diseases from occurring. How do you prevent diseases from occurring? From doing the things that will ensure that there are no diseases. How will you promote healthcare? From making sure that people are living a healthy or a well-being kind of lifestyle that promotes healthcare. So there are basic things that we are now shifting back. And some of these things really, I remember many years growing up, we used to have people we used to call borafias, who used to come to our homes to check, do you have, for us who were brought up in the village, do you have a pit latrine, you know, something like that. And we are now going back there because study has shown that out of the 70% of people that get into hospitals, they go because of preventable diseases. So we can prevent people from going to hospitals. Equally, scientifically, it has been proven that for every shilling that you invest in preventive and primary health care, you save up to 19 shillings in curative services. So this is a smart way of ensuring that we optimize the Kenya shilling that has become quite scarce in terms of how do we deliver healthcare, having optimized on the scarce resources that there is. So, Maria, we have identified 4 main pillars under which we are going to deliver universal health coverage. One of the pillars is on health commodity products and technologies. And this simply is the products that are used in health facilities. The medicine that a patient gets once they check into a hospital, the needle, the syringe that are used, the gloves, all that. We want to ensure that they are available, that when a patient walks to a health facility, they find when those things are available. So specifically to ensure that we work on that is we are leveraging on local manufacturing. We want to promote our local manufacturers. For those products that are manufactured locally, we ensure that we acquire them locally. That will give us 2 fronts. One, actually 3. One, that there'll be a reduction in lead time. You know, if you have to import a product, it takes longer to come into the country. But we are saying now, products will be within. 2 is the cost. When you are importing, there are many markups that are put on products, but if you are having to manufacture locally, then we know very well that we'll be able to bring the price down. But 3, which is very important, is that we shall be boosting the local economy, because for a manufacturing plant to be functional, it will create employment to Kenyans, not just to scientists, not just to health professionals, but many people. It is a whole ecosystem of an economy that we are going to create. There are people who are just going to be doing packaging. Packaging has nothing to do with the real health, but it has everything to do with how well do we deliver the product. So we are leveraging on local manufacturing.
And then when you talk about local manufacturing, so essential medicines is what you'll be looking at, most so definitely.
Medicine and other products that are used in healthcare.
So I'm wondering, does this also include, chronic diseases, diabetes, high blood pressure? Those are some of the diseases that, many Kenyans are grappling with at this time. Are those some of the medicines that we'll be seeing our local manufacturers produce from within? Or
exactly. Globally, there's an increase in NCDs, that is the non-communicable diseases, that is the diabetes, the hypertension, the cancers and all that. So locally we have capacity actually. There are a number of medicines that are used for hypertension, for diabetes, that are manufactured locally. What we get from outside is the API. API is the active pharmaceutical ingredient. That is what we'll be getting from outside. But after we get that, then they are manufactured here locally. So we are going to have a situation whereby then we are able to manage. When you are on this chronic illness, it's like you take drugs almost on a daily basis, based on the advice from the doctor. So we are ensuring that we bridge the gap to ensure that the medicine is available locally.
How then do you work with KEMSA? Because there's been hue and outcry in terms of commodities in hospitals. How then has the ministry will ensure or has ensured that these commodities will be found at the county level especially?
Thank you. And I think Kenyans know that lately there has been quite some stability at KEMSA due to the changes that we made in leadership. We have a new board that was skillfully selected of experienced people who can run the institution. We have a CEO also who has some good knowledge and understanding of how to run a critical institution like KEMSA. But having said that, one of the things that we are doing is we want to get into a national quantification exercise, that we are not just looking at the drug requirement for our public hospitals only. No, we are looking at what is the requirement. For example, if it is paracetamol, what do we require as a nation? What paracetamol will be used in a public health facility, will be used in a faith-based facility, and will be used in a private facility, so that we are doing national quantification to understand and then forecast what is it that we need. Because many of the issues that we have had at KEMSA is due to poor quantification, poor forecasting. We buy today, tomorrow we are out of stock. So we want to ensure that we have a proper quantification and forecasting being done nationally, that then we are able to project what is it that we need like for a year and plan for it. And with the local manufacturer, then we are able to give them framework agreements where they know that for the next 2 years, I'm supposed to be providing this item, this product or this commodity. So they plan themselves to ensure that there is no disruption in supply chain. But the other thing is that we want to do is to leverage on technology. We actually want to create visibility that somebody ordering from a level 2 facility. I come from Trans Nzoia County, Kiminini constituency, Sehendu ward. The nearest facility to me is called Weonia Health Center. So we want to have to leverage on technology so that whoever is manning Weonia Health Center can see the stocks at KEMSA.
Okay.
Kenyans know about Amazon, where if you want to buy a product, you can see the SKU of that, the code of that product, and be able to see is it available in stock or it's not, and at what price. Okay. That is exactly where I want to take KEMSA. I am a supply chain specialist. I believe it is possible. We are already working to set the infrastructure to ensure that we create a process where then there can be visibilities. What we have had a problem again, Maria, is that counties tend to consolidate their orders before they order. But we want visibility so that at least they can order directly of course with supervision of the counties, but at least products are visible across board.
Okay.
If a product is coming down, we are able to, and even us at the national level, we are able to see the quantities at the facility level. That will help us in terms of planning. So those are some of the things that we want to do at KEMSA. But as I had said earlier, again, leveraging on local manufacturing, we want to ring-fence specific products. I said earlier, and I'll keep saying, there's no reason why, as a country, we should be importing paracetamol tablets.
Yeah.
We have plenty of it in this country that is of good quality, because we have Pharmacy and Poisons Board, which is a regulatory institution. We have the National Quality and Control Laboratory. We even have a faith-based laboratory at MEDS to check on quality of product. So there's no reason why we should keep importing. Because, you know, importing, it means we are spending dollars.
And
yet dollars are scarce.
And it becomes expensive.
Very,
by the time,
very expensive.
You know, a Kenyan is going to the pharmacy to, you know, to buy medicine.
Yes.
Yeah, and you know, you also brought up, or at the beginning, we did talk about the promotive and preventive health. And community health promoters are the drivers of this, you know.
Yes.
It's been a journey from community health workers to volunteers, and now they are being, can I say, absorbed. You know, their policies to ensure that they are absorbed into the workforce or into the system. Probably could speak to us the importance of Kenyans embracing community health promoters. It's one thing that the government did flag off their 100,000 kits, but it's another thing if Kenyans will either embrace or not embrace.
Okay. Maria, globally, countries are moving towards focusing on the best, that is the primary health care. And as I said earlier, it makes more sense. It is a smart investment if you invest at the bottom. You invest less, but the benefits outweigh the cost that you put in terms of investment. These community health promoters, one, the reason why we have, the names have kept moving. We had those we call community health workers. But then we were going to be in a catch-22 situation, because our worker, there's a minimum wage that is expected to a worker. And we thought, as a country, we still do not have sufficient resources to be able to enumerate them well. Two, volunteer. There's so little you can ask from a volunteer. A volunteer is somebody, if they wish to do something, they can do it. If they don't wish to do it, they don't do it. So we were not going to be able to hold them accountable. And at this rate, maybe I just need to let Kenyans know, it is me who decided on the name of promoter. Because I said, what we want them to do is to promote healthcare. We are giving them a stipend on a matching basis between the national government and the county government. So with that stipend, then we are equipping them. The kits that you rightfully speak to, that His Excellency President launched last time, a kit is such an investment, you know. So you don't want to give somebody that kind of an investment and don't give them a level of responsibility. And that is why we are calling them promoters, that with a kit, with a gadget, with a stipend, then there's something we expect from them. But most important is that each of those community health promoters has a smartphone. On that smartphone, we have put an application we call EKIS, an electronic community health information system. That EKIS, from the headquarters here, we are able to see the activities of each community health promoter, because we have said one community health promoter for 100 households. So immediately they visit a household, we can trace and say this community health promoter has been working or has not been working. So now we have a mechanism of checking. But I really want to appreciate these community health promoters. Essentially, the work that they are doing, they deserve much more in terms of being appreciated for the work that they do. But they have agreed, you know, they have given themselves out to be able to assist Kenyans, to be able to assist the communities that they live in. And most important, Maria, is that these people, we did not handpick them from the national level. They were picked by their communities. Their communities trust them. They trust them with their health information. And that is why they actually, I'm told that they got through some sort of an election to elect, then now they come through the training. So we are just doing what has been documented. We are now moving from theory. This morning I was addressing a human resource for health workers. And I was telling them, as a country, as far as I'm concerned, we do not have a shortage of policies. All we need to do right now is to go into an implementation mode. This primary health care has been tried before. It is known to be the best, so we are now going into an implementation mode. But also to assure Kenyans, after the 20th, so what? We have an acceleration implementation committee to accelerate, to see what is it that happens after the 20th. After we launch, what will be happening within the counties. We have also identified 47 last mile delivery officers, who from here I am tasking each one of them, and they are well known to me, that I can pick my phone and call and ask what is happening in Viga County, what is happening in Turkana, what is happening in Lamu, what is happening in Kilifi, you know, so that then we are able to monitor each and everyone's activity and how we are going to deliver the
it's not
UHC.
just a matter of launching, but seeing it through,
yes,
the implementation and all that. I want to bring you back to the issues of chronic diseases, the non-communicable diseases, diabetes, cancers, and all that. You talked about an emergency fund. You know, could you elaborate on that? Because this is an area that most Kenyans grapple with. You know, there are Rambis everywhere, WhatsApp groups just to help Kenyans, meet medical expenses. So there's going to be a shift in that area?
Yes, there's going to be. And at this juncture, I want really to thank the legislators of this country. I want to thank my officials here at the ministry, because when we started the journey, many thought that it was not going to be possible. But within a record time, we managed to take the bills to cabinet. I managed to convince cabinet, they were approved, and they were moved to the National Assembly. We have seen progress on the bills, that the two that originated from the National Assembly, that is the Social Health Insurance Bill and the Digital Health Bill, were able to be passed in the National Assembly, and they are now in the Senate. The two that originated in the Senate, that is the Primary Health Care Bill and the Facility Improvement Fund, have now crossed over to the National Assembly, so they went through Senate. Now we are waiting for them to finalize. I am confident that the legislators of this country, the members of parliament, do understand that we are at a place that we must shift. And for us to shift, we must anchor our decisions on some legislation, on some form of law. And by the way, the reason why this universal health coverage didn't work in the previous attempts is that there was no legislation to anchor the decisions on. But now we have it. Most important, and that has elicited a lot of discussion, is the Social Health Insurance Bill. Because this bill seeks to introduce 3 funds. One of the fund is the public health, the primary health fund, and this primary health fund is for the level 0, that is the community health promoters, level 1, sorry, then level 2, to ensure that every Kenyan who walks into a facility, then they are able to access health services without having to pay from their pocket. That is very important. Then we move to level 2, where now we introduce the social health insurance fund. This social health insurance fund, we are having to have Kenyans to register into it. But that is only once you have now been referred to level 3, level 4 of healthcare or upwards. That is when your social health insurance kicks in. And His Excellency the President has said that those with high income will pay a little bit higher. Those with the low income will pay lower, commensurate to your income. You have rightfully said it that many Kenyans, even me today, I have several WhatsApp groups that are asking me to contribute to health. But now we want to do like a public, kind of WhatsApp group, one major one, where we all contribute. Those who have high income, like myself and you and many others. Those with low income, then we are able to take care of them. But the third fund, which is the most important, and I have said it that since the promulgation of the new constitution, they said Kenyans have a right to emergency healthcare when it happens. Like if there's an accident, a casualty is taken to a health facility, they're supposed to get care. They have a right to it. But currently what happens is an accident happens, a bomb blast happens, casualties are taken to a health facilities, they're not given service. Why? Because the facility is not sure who is going to pay. And they are right to demand, because they are going to input resources, to input products, so rightfully to demand. So what we have done is to come up with an emergency chronic and critical illness fund. Should there be an emergency, should there be an accident, then the casualty just needs to be taken to the nearest facility. and they'll be taken care of. We are suffering from NCDs, which you have brought it up. Those are chronic illnesses. Then we now have a fund that once it is determined that your disease is chronic, it is diabetes, you're going to be in drugs for the long haul. Then the critical illness and chronic illness fund kicks in. We have cancer. It is now on the rising case. So once you are determined or diagnosed to have cancer, then the critical illness fund kicks in.
To that fund.
Yes, you'll be eligible to that fund.
Thank you so much, Cabinet Secretary. Our time is really running out, but I have a lot of questions to still ask. But there is something I don't want to go without asking you, and that is the WHO,
yes,
the World Health Organization, did approve the vaccine that was trialed in Kenya, the malaria vaccine.
Yes.
How significant is this news to Kenya, especially now that Kenya is also in the process of, manufacturing its own vaccines? Maybe just a briefly.
Oh, thank you. That is quite something in terms of management of malaria. Actually, if you look at the beginning of the Millennium Development Goals, malaria was one of them in terms of elimination of malaria. We didn't quite eliminate it. It moved from a Millennium Development Goal to a Sustainable Development Goal. So now under the Sustainable Development Goal is to find out exactly what we need to do to eliminate malaria. Okay. It is proven that vaccines are the surest way of preventing illness. Remember, we've said we've moved to prevention and promotion. It is the surest way. So WHO has now announced, and normally when a breakthrough announcement like that comes in, there are those originator companies that then have the whatever to produce those vaccines. But as time goes by, other companies are able to manufacture similar formulations or a similar vaccine. Okay. In Kenya, and I'm very happy to, and I really want to thank my cabinet colleagues, that sitting in cabinet on Monday in Kisumu, we did approve our Emergency Response and Resilience Program, which is to operationalize BioVax. That is going to be manufacturing a vaccine for us. One, they are going to start with what we call fill and finish. Fill and finish to mean that they will import the vaccine from somewhere, but in terms of packaging and filling them into either ampules or vials will be done here locally. But as time goes by, we build our institution, we build the Pharmacy and Poisons Board, because you see, we cannot do vaccines just for ourselves. Would like the Kenyan market for vaccine is about 30 million doses a year. The East African market is about 150 million doses a year. There is no other vaccine manufacturing within East
Kenya
Africa.
Is looking to export.
So Kenya, we want also to be able to move it. So one of the things that we shall be doing under this resilience program is to capacity build Pharmacy and Poisons Board. That then they are recognized by WHO to do what we call batch releases. That once it's manufactured by BioVax, Pharmacy and Poisons Board checks it, does a batch release, then we are able to sell outside this country. So I'm really excited about it. I think it is going to be a game changer. Many Kenyans suffered, for example, during COVID. Some countries that had vaccines hoarded the vaccines. They didn't want to share it. By the time the vaccine was arriving in Kenya, and let me say not just Kenya, but like the global south, many people had already developed some sort of immunity. Right now, we have to beg people to go and get the COVID vaccine. But had it been that we had our own vaccine, you see, it would have been easier. We do not know when the next pandemic is going to happen.
Exactly.
It's just a matter of time.
It's a matter of time.
So the earlier the better if we start on a journey of self-sustenance, that we are able to have our own vaccines. But again, I was going to forget, Maria. As a country, we were rebased by the World Bank from the by IMF from lower income to now lower middle income.
Exactly.
What that means is that then we have to gradually move out of donors and partner support. Can you imagine if they were to move out on vaccines, yet we are not ready to sustain ourselves?
So definitely putting up this infrastructure is
so
key.
We have to put in place the infrastructure. That is why we must operationalize Kenya BioVax, so that by the time we are graduated to a point that now they are living, we can stand on our own and take care of ourselves.
Asante sana, Waziri, for those insightful information and all that. I'm sure Kenyans have learned quite a lot from just the information that you've shared. But I want to give you 2 seconds,
Yes.
just to invite Kenyans to the Mashujaa Day. Yes. So this is your camera.
Oh, thank you very much. Let me start first of all by appreciating my team here at the ministry. People have worked day and night. I would really want to mention names, but at times I feel like the others will feel like, oh no, the minister did not acknowledge me. I want to acknowledge everyone because the team has worked hard. You remember this was a promise, and it is easier to promise on the campaign trail. But we have gotten to the level of implementation. It is because of the hard work that has been put in by my staff at the ministry, the hard work that has been put in by stakeholders, the hard work that has been put in by our parliamentarians in both houses, and the hard work that has been put in by my executive, the people in cabinet that I sit with, who have continued to assist me when I bring my papers to cabinet, then they are approved. So I really want to thank everybody who has put in effort, the partners who have assisted us. Actually, I forgot to mention about primary care networks, which is like the basis of how we are going to reorganize ourselves, that people are into a network. We have been heavily supported by partners. Up to the level of even buying the kits, we were supported by partners. We are now doing digitization for all the facilities to connect them into a PCN, supported by partners. Even moving forward, I know they are going to continue to support. So I really want to thank them. But having thanked them is that now they have enabled us to be at a platform where now we can stand and say we are launching UHC on the 20th of October. That is next week, Friday. I want to invite Kenyans. Please come out in large numbers. We have staggered our celebration. We began today by a conversation about human resource for health, where we are looking at production, the training institutions, and all that. So we have scheduled days of celebrations. We speak about health, the workers, we speak about the products, we speak about technology, we speak about financing. The culmination itself is on 20th in Kericho County, the green county, so I'm told, that has a lot of tea, a lot of fresh air. Please, Kenyans, come out in large numbers and celebrate. This is going to be the first Mashujaa Day where we shall have a parade mounted by community health promoters from across the whole country. It is going to be quite something. Kenyans, please come out, watch, celebrate with us as we launch this UHC. But equally, as a minister, I want to promise Kenyans, it is not just about the launch. We have a plan on what happens from the 21st moving forward. Karibuni sana wa Kenya, Kericho County.
Thank you so much, Cabinet Secretary Susan Nakhumicha. She's been talking to us about universal health coverage and all that it entails. So I hope back at home you've gotten the message. Promotive and preventive health is your personal responsibility. Thank you once again. My name is Yambo. Hope to see you again next time.